Good evening, everyone. Thank you for joining this panel discussion by ChintaBAR on uh, the COVID, India's COVID response. And we have with us two esteemed panelists today, Professor T. Sundararaman, who was formerly the Executive Director of National Health System Resource Center and currently the coordinator of People's Health Movement. And also we have with us Professor Ramakumar, formerly the member of Kerala Planning Board and faculty at Tata Institute of the Social Studies. We'll first proceed. We have tried to structure the discussion as follows. Professor Sundararaman will initially discuss on the public health response to the pandemic, followed by Professor Ramakumar discussing on the vaccination policy. And then we'll open the floor for discussion to the audience. Thank you. And I request now Professor Sundararaman to take over. Thank you, sir.
Do you have the share screen?
Yeah. Yes, please. 1 second.
That's that. Okay, let's go. I'll take you through a whole of the public health domain. My frustration has been largely that people don't understand, even when they talk about it, what we really mean by public health. And it's not only the problem of the outsider, even problem of people within the medical profession. So it's a good opportunity to go through some of these issues. And let me start with a thing, and it's an overview presentation, and I'll try to give you a sense of what are the areas that we cover. Now, when you have the first part, the understanding the pandemic wave, you have seen this figure now more and more. It almost looks as if the first wave was some sort of a pilot program, a very, very small dip. At that time, it caused terror. It was 1 lakh cases per day, which was still among the world's highest. And we were overwhelmed at the month of August, September, because the lockdown had been for very long and it had not stopped and it was worsening. Then to all our surprise, it started coming down in November. And the feeling was created that the problem is over, but only to be struck by one of the most brutal second waves anywhere or first wave anywhere in the world. The wave that started in March and peaked into April and early May and then came down when it reached 400,000 cases per day and crossed close to 5,000 deaths per day. An incredible number of cases in a very brief period of time. And even now when we say that the wave is ebbing, what you find is that actually the total number of cases, say in Tamil Nadu, is still higher than what it was in the first wave. So we are not really out of the second wave. But the fact is, we more or less have already agreed that a third wave is likely. Now, this is across the South Asian countries. I put Nepal, I put Pakistan, I put Bangladesh, Sri Lanka. What you see common in them is waves. But you don't necessarily see the same first wave, second wave. For example, Pakistan seems to have a middle second wave and then a third wave, a second wave slightly smaller, whereas in Nepal, you have a first wave and a second wave very similar to our pattern. But you have a number of things. Thailand is actually quite at the bottom. It has a wave, but that wave is only not a wave by international standards. It's only a blip over there. But you do find, the point I'm trying to make is that waves happens across most places. Now, in that last map, in that last picture, I did not show India. Because if you show India into this, the number of cases in India is so high that on scale, you can't show the pattern. So here is Bangladesh, and this This purple one is Bangladesh. I'm going to compare it with what you see in the next one. And you can see that Bangladesh, that big curve there is a small blip compared to India's curve. And over here, that small first wave you saw in Bangladesh is not even visible. But therefore, I'm trying to make a sense of the fact that scales matter. And that's a huge difference in the scale in which India happened. Now, why did you have a second wave? Could it be because of a mutant strain? Yes, there was a mutant strain. But to say causality, you have to say in some sense that it can reinfect people who were infected in the first wave, recovered, got reinfected. That did not happen. So in some sense, it was going only in the unimmune population. Now, in an unimmune population, when a virus spreads, and there are many strains out there, because the virus keeps mutating, hundreds of mutations occurs. Any mutation that gives a small advantage in transmission, however small it is, will dominate the whole scene. Therefore, in any second wave, in any subsequent wave, one or other strain will be dominant. It depends not only on the transmissibility of the virus, but also the starting points. If suppose a number of foreign travelers had come from UK and it had spread from them, you could have had the UK variant, as we had for a long time in the north, in the Punjab area on that. So in UK, you have the UK variant, Brazil, you have the Brazil variant, South Africa, you have the South African variant, India, you have the India variant. No big deal. But it does matter also. I mean, at one point, I'm saying you can't say there was a mutant strain and therefore we had an epidemic as if it's an act of God, an act of nature that was beyond control. But you do know that these viruses are classified as viruses of interest and of concern and as of consequence, because there is a potential that the virus will mutate to the level that it will escape the vaccination immunity or the past infection immunity. Then you have a re-pandemic. And therefore, it is important to observe mutant strain. What I'm trying to say is, while I am not pushing the hypothesis that a mutation was the cause of the second wave, I am not denying that it was associated with the second wave, as always it will be, but I'm also emphasizing the importance of genomic surveillance to watch out for potential mutant escapes. Now, could it be because people ignored physical distancing, that log zimmedar nahi the, that people were irresponsible? What to do? Whatever you tell, people are not responsible. Then, of course, it will spread. Well, to some extent, it is true, but there are some problems with such an approach. First, why did it decline in November 2020, where you had the Bihar elections, festival seasons, relaxation of lockdowns, loss of social distancing, you had everything there, but it declined. Okay, and it isn't that, no doubt that election rallies and Kumbh Melas were actually fire on the wind blowing into the forest fire, setting it ablaze, accelerating it, definitely accelerating and amplifying events. But it happened even where the Kumbh Mela had little impact, like in Kerala, of course, had elections, but in Karnataka and other places. So to some extent, there is a relationship, but you can't attribute all of it to it. And it's important for us to have adequate public health. So no doubt physical distancing is an issue, but it is not the entire explanation. Now, we do need to know that while all second waves are very common, and therefore we have to look at it as something generic happening across the globe, we also note the exceptions, that countries like China and New Zealand did not have significant second waves, and some had very manageable second waves like Taiwan or Australia, South Korea, and Vietnam, etc. Now, one of the reasons is it spreads along social networks and clusters. So village or some part of a village that is linked by a social chain of transmission gets saturated with the disease, or even in those who are not diseased, because they are all associated, they tend to have behavior changes, and therefore soon the virus doesn't find enough unimmune people to spread to, and it slows down. But herd immunity has reached, herd immunity being the proportion of population who is immune, has reached only to 25 to 30%. So 70% to 75% are unimmune. And therefore, this virus can easily spread within the 75 and give rise to the second wave. And this time when it goes from one set of transmission chains into another set, acts like a lull, a trough between the two waves. Now, the way to break this is to have good disease surveillance systems that monitor the entire system and identify outbreaks when they are small and localized and take joint action to prevent it so that they do not spread. But left alone, these many isolated clusters can snowball into a forest fire, and there they amplified by elections and Kumbh Mela. But the other problem in this is the whole issue of stigma and denial, where people's cooperation in disease surveillance is critical, but it doesn't really happen. Now, some things about the second wave, it was the rate of growth was 4 times the first, much greater diversity of symptoms. Maybe as a proportion of the population who are affected, the youth were not affected more than in the first wave. But in absolute numbers, both mortality and the number of youth who died, or younger people below 45 who died, were much higher, because the total numbers were higher. As the disease goes into the third wave, more of the elderly are going to be vaccinated, and younger people are going to be unvaccinated. So we are going to find a shift in cases to the younger section, not because of a change in the property of the virus, but because of a change in the way in which the unimmune are available. And because of this change, mutant strains that have greater penetration in the young can increase, and potentially there is a bigger risk for the young as we go down because of just the way in which interventions have happened. This is something that we need to understand. And stopping the third wave, therefore, means a countrywide disease surveillance program, engaging communities in public health measures, the big gap we have had so far, and universal vaccination. Okay, it's too late to stop this wave. Perhaps, just perhaps, we will be in time for the third. Almost, I don't want to be very pessimistic and say we won't make it, but well, at least we can give it a good try. Now, what are the most important public health challenges? Or in some sense, let me look at these 8 challenges and what we got right and what we got wrong. I'm going to leave one of this to Ramakumar. I'm going to save myself the time and say I won't talk on point 7, getting vaccinated and universal vaccination. Point 8, I don't have the time. I don't want to really elaborate on that. Non-COVID care, social security, food, the loss of livelihoods, the damage in the socio-economic areas. It's also public health. It's also very important public health. If you die of TB instead of dying of COVID, it's not because any big credit to our COVID control mechanisms. So the issues are important there also, and they are public health also. But simply because of time and because the concerns that I need to cover, I'm not going to be able to get into that. I'll brush over it. But I want to talk to you about some of these big things. And one of the big things I want to talk to you is this phenomena of stigma and denial. Stigma is a sense of shame, guilt. It is also an abhorrence, avoidance of others. Shame and guilt is self-directed, abhorrence and avoidance is directed. And you have this in a big way. Tamil Nadu particularly so. It comes up as vaccine hesitancy, but I don't like that word, a vaccine hesitancy, because it's a concept of people who are refusing vaccines because they are in a general rejection of science. It's a postmodern problem. Whereas what we have here is something really pre-modern, a lack of awareness, a feeling that it is punishment, that disease is divine punishment, that there is something wrong that we have done. So it comes through softly in the official messaging. that up Lakshman Rekha le lo, you be within the Lakshman Rekha, the way the police, for example, catch you, fine you, the way FIRs are filed. So there is a certain criminalization of disease that occurs. And along with it, an othering of the disease. So it is the Tablighi Muslim who is spreading the disease. Otherwise, we are very well in control. That sort of thing, always finding somebody. So you will say that in an apartment, because of all these housemates coming and going, where the apartment people in the apartments are at risk. You won't say because the maids have to come to the apartments, they are all at risk from these people in the apartments. So this whole thing cuts in one direction, and it's a direction of power and marginalization. And stigma is always iniquitous in its consequences, inequitable in its it affects the marginalized more, and they have a huge problem. And one of the coping mechanisms at the community level is denial. So you'll go into a bad slum, for example, in the Tirvanmiyur slum near Valmiki Nagar, you have that there is a slum, and beyond that there is a deeper slum where even most houses don't have toilets. The public toilet is poorly used. You have there you will find nobody has the disease. There's a complete denial. We don't have it. We don't have any such problem in our area. Please go away. And if they have a fever, they'll hide it. They won't get out of it because all these messages of social distancing you're giving them, they just can't follow. It's just impossible beyond that. And the only way they can cope is to say duck and hope it passes whenever it will pass, and therefore be in denial of it and go away. So you have this, or you have people saying, oh, my village, there is no such disease. These people, they went and got tested and they got positive. Otherwise, or these health workers are paid incentives, so they come and catch. Different, very perverse forms of denial of the disease that happens. But denial is not a phenomena just at the community level. But I must tell you that this phenomena of denial of the disease, in Aligarh, we were ringing up somebody and asking, persuading that person with fever to get tested. The doctor comes on and says, "Hamare dehat mein aisi koi bimari hai nahi." In Aligarh, at the time when bodies were floating in the Ganges, there's a doctor who can deny that there is any COVID-19 in his villages. So denial is a very powerful thing that is happening. And at policy level, there is a denial. Civil society is full of conspiracy theories. Full of conspiracy theories of how big pharma, and there are actually no disease, there are other diseases. There are so many levels and mid-management level. So these are problems of public health. And a need to counter it if you are going to make any difference. When we are talking of COVID-appropriate behaviors, there's this whole discussion about aerosol transmission and droplet transmission. Aerosol, for our practical purposes, is a very, very tiny droplet. And at some point, all it means is it doesn't spread through the air in an indefinite way, that it doesn't spread from hostel to hostel through the air. It doesn't do that. It doesn't go from room to room. What it does is it goes only from people, but when you say aerosol, it can hang in the air for a longer period. So reduced to the actionables, there are 5 things that are important. Avoid crowded places, much more so if it is indoors. Maintain a distance, preferably of 6 feet, and preferably with mask. Keep the room open and ventilated, because air circulating within, as an air conditioner makes it happen, is much more dangerous. So air conditioners are particularly dangerous. Keep hands clean and cover coughs and sneezes, and wear masks, especially when you can't physical distance. I'm not one of those who wants to wear mask when you're driving a scooter down the road. I think there's no danger of spread to anybody. But when the policeman stops you and fines you, yes, you may catch it from the policeman. And you may catch it from the other people who are stopped to be fined over there. So for that reason, I think you should wear a mask when you drive a scooter. But the chances that you cross a person who is COVID-19 positive and in the air you will get it from him are 0. Now, other than these 5 behaviors, you can add 2 more in, which is important, which is if you're unwell, stay at home, and stigma and denial itself as a behavioral issue. Now, this is again saying the same thing. They've called it the 3 C's: crowded places, close contact settings, and confined and enclosed spaces. And to the extent that these 3 factors overlap, the risk is even higher. This is a very simple way of remembering where the risk is. Avoid this, your chances of spread are low. Now, physical distancing. Now, the question that you really ask is, why have we been a public health disaster? It's not a sense of saying people don't do it. Health education, behavior change, communication has a whole history. 50 years of public health training teaches you how to do it. And one of the important things is that you don't do victim blaming. You don't say that, you are sick because you are guilty, because you did not follow it. It doesn't help. It doesn't change behaviors. Nor does a law and order approach that uses coercion succeed. In fact, in Tamil Nadu, they were monitoring behavior change by the number of fines collected and the number of cases filed. Wasted effort for many reasons. And in some sense, you think that it helps to some extent. It actually doesn't. The thing is, as this poem goes, that we are not all in the same boat. We are in the same storm. Some are on super yachts and some have on just the one oar. It's a Twitter poem. But at some point, it's an interesting poem because it says that the conditions under which people are, many just cannot follow this. And when you need to do behavior change communication, you need to segment the audience, understand the determinants in each segment, and then build appropriate messages and medium, and use interpersonal communication as the main form of behavior change, but supported by building an environment of the message. So it's all right to have the message with Amitabh Bachchan speaking in the TV, but that's just a general background support that you create. The actual change occurs in individual communication, and we did none of that. We almost had no actual health communication campaign of the scale, diversity, and depth that you required to have made an impact on this. And part of the reason is our weakness on primary care. And these need to be actually very, very appropriate dialogue, to dialogue with people and come to a joint understanding of what are the changes that can be done. So let me sum up. To ensure COVID appropriate behaviors, you need to stop victim blaming. You need to desist from a law and order approach. You need to address stigma and denial. You need to be evidence-based, well-designed health education, communicated strategies, and you need to engage with communities. Now, let me take the next part on test and track, quarantine, and isolate on this. Now, once the DG was asked in the beginning, during our lockdown, what is the most important measure? Instead of stating the lockdown, the WHO DG said test, test, test. Later he modified it. But at that point, the importance of testing was still being recognized. Now, the importance, whom do you test? You test anybody and everybody who has a symptom which is suggestive of the disease. So a fever, a cough, a running nose, or a headache which comes on acute onset, you need to test. Even if there is no history of contact, even if there is not a hotspot. To arrive at this conclusion, we took till July, August. Then only we opened up to testing. And we kept saying that there is no spread beyond the tablighi because we didn't test anybody beyond that because our rules prevented testing beyond that. Now, if symptoms are over 5 days, then it is getting dangerous and complications are likely. We also test close contacts. So if they are symptomatic, you test immediately. But if they are asymptomatic, if I am infected, I am positive, and somebody has come into close contact with me today, I don't test him tomorrow. I test him after 5 to 7 days. That is the incubation period of the disease. Between my passing infection to him and him manifesting infection, it takes 5 to 7 days. And therefore, you need to test 5 to 7 days later. So this is an important issue on this. And in India's testing capacity development was a huge achievement. We are now testing close to 2 million kits per day. And we have now largely domestic production and huge, more than 3,000 laboratories. And there is no monopoly. Unlike vaccines, there are more than 20 manufacturers and kit manufacturers. So you have actually an achievement. But despite that, there are huge problems. Delays in the testing, rapid antigen tests. If they test negative in a positive symptomatic person, you need to repeat RT-PCR. Huge and growing costs and overcharging in the private sector. No quality assurance for test kits, and continued improvements in test kits for new strains are essential, but little is being done on that. So there's a number of problems which in testing, which are very iniquitous in its expansion of the testing capacity. But even greater failure. So my sense of it is in testing, if you leave the fact that we did a late start, countries like Iceland and South Korea and Taiwan were off to testing even before the first COVID-19 case had occurred in their country. They heard an epidemic is going to come. They got the virus genome. They got their labs to manufacture the test. So, but the test kits were in place. We started looking for testing kits on March 22nd, and our lockdown was starting on March 23rd. Our first meeting in the ministry was on March 22nd. But if you can overlook the delay, by November, we had actually cracked the heart of that problem. In contact tracing, we never did, even today. While in the first month, we did a little bit of contact tracing for international travelers coming in and quarantining them in hotels. Subsequently, we gave up on contact tracing, partly creating a thing that there is no transmission, and also because of the overall reliance on the law and order approach and the physical geographical containment. So if there are 3 cases in the apartment, you lock the whole apartment down. There are 2 cases in the street, you lock the whole street down. It's ridiculous. It actually, the virus doesn't spread house to house. It spreads through contacts, and if the houses had contact, it will spread. Otherwise, you're testing unnecessarily, confining unnecessarily, and most important, you are not finding out. Nobody comes and inquires who were the contacts with. There is a lot of curiosity of whom you got the disease from, which is actually quite irrelevant. There is some relevance at another level, but you know with certainty whom you could have given the disease to. And if you would identify them, you could, if you say, okay, in my department, nobody has the disease, but this fellow has tested positive. So immediately you find out whom all he was working with and ask those fellows to stay at home. Then it is likely that in your department, it won't spread more. So as a national strategy, it has its role, but in every place you will be able to warn people, safeguard people if you have good contact tracing. And contact tracing in India is marked by its complete absence. And there are lots of implementation issues, why it's not done, which I've gone through. And there are a whole lot of mechanisms where you need to know how you should do so. And a contact is not just anybody. If you cross him while walking on the road, it's not a contact. But if you have been face to face for 15 minutes at least without a mask, it's a contact. Or if you have been in an enclosed room for a length of time together, then also it's a contact. So in some sense, even though you may not have been face to face. So the understanding of whom it is likely to affect is important. And then when you catch them, you have to either decide on home quarantine or institutional quarantine. Institutional quarantine is ideal, and countries that have had the best control have done that. But for us to isolate a person who has not even got fever or may not get fever is very difficult. So home quarantine seems to make sense. But when it comes to isolation, so quarantine is for those who do not have the disease and may not have the disease, who have yet to develop the disease. Isolation for those who have the symptoms of the disease or who have tested positive. Now, isolation at home is not a good option. Isolation must be in a facility and institution, and that is called a COVID care center. Okay, and if it is at home, then it requires a high degree of support. Institutional isolation, they used government hostels. In fact, the best isolation center was in IIT Madras. I know that because I have some privilege. So one of my relatives needed to be in isolation and got her sent to IIT Madras isolation center, which some hostel it is in. Very good isolation center. So isolation centers can be excellent. Mostly college hostels were converted into isolation centers, and people, their food, water is taken care of. They don't go out hunting for a job. They don't go out to the public toilet. And it actually prevents spread in a major way. When you say home isolation, very often you are just being too clever by half and abandoning care and calling it home isolation as if it's a proactive strategy. If it is a strategy, then you need to have home visits, you need to ensure separate room, utensils, clothes, toilets, that even in a 3-bedroom house is very difficult to achieve. You need to ensure that minimum safeguards are followed within the house. You need to ensure that fever is checked with a thermometer twice a day. Not an easy thing to do. If you don't know, if your numeracy is weak and you can't make 98.4 as would happen in any slum, any poor family, and you have to have this pulse oximeter and be able to see the oxygen level, and below 94 you have to check twice a day. Those things to organize for home isolation are very difficult. So what you are actually doing is the Ram Bharosa mode. You just leave them there and dignify it by calling it a strategy. But you don't actually implement a strategy. It's a denial of care if you have not actually looked at them with the pulse oximeter, because most of the people who die come to a hospital late because they were trying so-called home isolation and did not notice they're slipping into hypoxia. And when the last minute they are rushing around, they may not get even a bed in time for that. And you need to actually be able to get this done. So there is a whole lot of areas in which we have spoken. So to summarize, these public health measures, as different from behaviors, it is addressing inequity in access to testing, quality assurance and further scaling of tests with volunteers and community as partners, better understanding and how and why of contact tracing, follow up to contact tracing with quarantine and isolation, better support to home isolation, much greater information on quarantine and isolation. I know one person who just be sick, you've been taken to a engineering college hostel in the middle of the night, and he wonders, if I'm so sick that I have to be moved by ambulance, why are they taking me to a hostel instead of a hospital? We don't think of communicating this to the public. We think these things are obvious. We don't really understand. Now, I'm not going to take you through this, but I'm going to just mention there are 3 types of center. The first is for isolation. The second may have oxygen beds. The third is the full thing. You have ICU beds, ventilators, and you know the huge problem of oxygen we had, of getting drugs we had. But the important thing is a good clinical judgment. A doctor who can look at the 5 parameters, the right diagnostics, the right medicines, oxygen, intensive care, and look at what you need to give when and give that accordingly. So, and you need a good public health logistics for about. So in terms of supply side, there are many challenges, but in demand side, let me put it very simply. There is a single right, our obligation of the government to provide free treatment. So if a sick person reaches a government hospital, it is the responsibility of the government to shift that patient to wherever the nearest bed is available. If they don't have beds, they must admit. If they don't have beds, they must shift it to the nearest place a bed is available. And if there are no beds there, they must requisition the beds. They must commandeer the beds from a private hospital and admit. For Pondicherry, for example, there are 600 to 700 beds in Jipma. There are another 600 beds in the State Medical College Hospital. Both of these got things, but the state hospital had a triage center, and any further case was sent to 300 beds were captured or brought under public authority from the private colleges around. They were placed under the private authority, 6 colleges, and 1 hospital was taken over by the government and placed under public authority because they were refusing to admit the cases. So 1 taken over and 6 brought under public authority, you expand the capacity. This is why the powers of the National Disaster Management Authority have been given to you. Not to beat up some poor migrant on the charge of jaywalking when he is trying to get home, not to appear very brave before people on a mask or trying to get their essential rations or reach a toilet. but to actually be able to exercise influence on power, where people have and where you needed to do this. This right, if it is won in this grounds, it can become a ground for future health rights, and therefore it's important to do that. A huge exploitation from the private sector, lot of unnecessary care and cherry picking and treatment of cases which we need to gather. Now, I'm not going to go too much into this. There are only 2 slides I will show. A lot of the preparation that needs to happen before the pandemic. And that relates to major increase in public health expenditure. We need to reverse the decisions on privatization of district hospitals, bring in a comprehensive regulation of private health sector, address the crisis in oxygen supply through a much greater expansion of emergency care in normal times and in-hospital oxygen plants, set up domestic manufacture production of all essential medicines, diagnostics, PPE required, and safeguard rights of health workers. So learning from this pandemic, there are things that we need to do for the future of this. Now, as I said, I will skip this. And I will say that these are the other concerns on this. Sustaining essential non-COVID essential health services, lockdowns and movement restrictions, to use it in a very limited way, only at times of peak transmission, based upon evidence as to which are the basic interactions where it is happening, and to manage the fallout, the collateral damage that lockdowns causes is a major issue. Then there are issues on key human resources for health and key challenges in governance, which require to be actually thought through. Okay, I'll circulate this to you because there's only so much you can listen to, and I'm well over my half an hour. And remember that respond with limited disruption of social engagement. So in a sense, a lockdown is a failure of public health. Even if it is posed as a public health measure, you basically mean that you have lost your reliance and ability on the others. You're no longer able to contact trace. You're no longer able to limit the spread. You don't know what the hell is happening, and you shut everything down. It is really burning the house to catch a mouse. Okay, and therefore there are things on the human resource for health and governance. And one of the things I wanted to check in this is the learning adaptive systems of how you learn from past episodes to build better systems in the future. Thank you.
Thank you. Thank you so much, sir. That was a very enlightening discussion. And now let us move on to Professor Ramakumar's discussion on vaccine policy.
Thank you, ChintaBAR and Vinod and others for organizing this meeting and having invited me. I was also very fortunate to have been preceded by one of the foremost public health experts in the country, so that he has laid the ground so beautifully that I can easily build on what he has already laid on. My job is to speak about the whole question of vaccination and the problems that have arisen therein over the last few months. Now, in doing so, I'm not going to use slides. I have slides, but they'll become too detailed. So I'm going to desist from that. But what I'm going to do is to make a broad point about why the vaccination policy of India has been problematic, why it is marked by a flawed policy and planning exercise. That is the first point that I would like to make. The second point that I would like to make is related to the whole question of deregulation of vaccine prices and liberalization of the vaccine distribution. This is the second, and how it has evolved and why it has become what it is now. This is the second point that I would like to make. And the third is what I would like to make is a case for a free and universal vaccination in the country. and I shall try to list out a few reasons why I think that should actually be the case. Now, the first point that I would like to start with is the question of flawed planning for vaccines in the country. Now, there was always this back of the envelope calculation possible. Government of India has much more data than us on the following. If you want to vaccinate everybody above the age of 18, you have to vaccinate something like 97 crore people. Now, 2 doses for 97 crore people would mean something close to about 195 crore doses. That's what you need. Now, if you want to complete the vaccination exercise for all of these people by about 1 year, about 12 months, then very clearly what you need is about 16 crore doses a month, or in other words, about 54 lakh doses per day. If you have 54 lakh doses per day, then you can complete this exercise in 12 months. Now, that is the broad calculation that anyone with basic availability of data on population and other details would have come into. This is the demand for vaccines in India. Now, here, remember, we have not included children here, less than 18 years, or minors here. That will be another about 30 crore if we add that. But we are keeping that out for the time being. So 54 lakh doses is what would be required. That's the demand. Now, if you look at the supply of vaccines in India, it was very clear that if you want to have 54 lakh doses per day, then relying simply on Serum Institutes of India and Bharat Biotech will be inadequate and insufficient. Okay, look at we started this exercise in January. Okay, the vaccination exercise, but we started planning for it from the last summer itself, April, May 2020 itself. From that time itself, it was very clear that the broad capacity of Serum Institute of India cannot exceed about 6 to 7 crore doses per month. Okay, that is the supply side of the whole point. Remarkably quick and extensive expansion of capacities will have to be made if Serum Institute of India has to move ahead from here. If you take the other company, Bharat Biotech, it's a small company. Okay, it is nothing compared to what Serum Institute of India is. They always produced only about 60 lakh or 65 lakh doses per month, not even a day, per month. Okay, that was the kind of availability that was there from Bharat Biotech. So about 6 to 6.5 crore doses from the Serum Institute and about 65 lakh doses from Bharat Biotech. Add both together, you are somewhere around 7 to 7.5 crore doses per month, and not more than that. Okay, now 7 to 7.4 crore doses per month is less than about 30 lakh doses per day. In fact, about 28 lakh doses per day. Now, what you need is about 55 lakh doses per day to complete the exercise in one year, but you have only about 28 lakh doses per day at best. Now, even this 28 lakh doses per day is a suspect number. I'll come to that later when I'm speaking on that particular subject. Now, there's an additional complication in this whole process. All that we produce in India, that is 28 lakh doses per day, or about 7 to 7.5 crore doses per month, is not available for distribution or use in India alone. Okay, India has 3 kinds of commitments that are there globally. Okay. First is Serum Institute of India has commercial commitments abroad, particularly to the donor company called AstraZeneca. Donor means whose vaccine you're manufacturing in India as Covishield. They have commitments to supply them a certain amount of doses. Second is there is a scheme called Vaccine Maitri, where the government of India has been supplying vaccines to friendly, less developed countries across the world. That is the second area where you'll have to provide vaccines. And the third is India has commitments under India, and also Serum Institute has commitments under what is called as Gavi or COVAX facility of the United Nations, and handled by WHO, where you have to supply a certain quantity of vaccines produced in India, donated to them, roughly about 10 crore doses have to be done over a period. If possible, it has to be raised to 20 crore. Now that is a third commitment that you'll have. So all the production you have in India cannot be simply used for domestic purposes. It has to be given out as well. So you have to discount for that as well. That's why when the crisis came, the government banned exports because we simply did not produce enough. So this was the broad situation in India right from the beginning. You knew very clearly, the government knew very clearly that you are not producing more than 28 lakh doses per day, while you require about 54 to 55 lakh doses per day to complete the whole process in 1 year. So here is where we come to the question. I want to highlight three major problems of vaccine planning in India in this context. Okay, in this context of demand supply calculations. The first is that did the government of India know of these constraints, and did it take steps to tide over an anticipated deficit that might arise in the future? Three things could have been done. Okay, one is, if you look at countries across the world, you will see that most countries of the world have a diversified vaccine basket. Okay, they don't. I'm not here talking only about technology choice, that is about adenovirus or inactivated or protein subunit or mRNA. I'm not talking about that. Of course, that is technology choices also have to be diversified, but more companies and their vaccines were given permissions in many countries, looking at the anticipated demand for these vaccines and the need to complete vaccinations as early as possible. So India, however, has been a laggard in this whole process. Okay, India has been extremely conservative about giving permissions or emergency use approvals to a diverse basket for vaccines, and the reasons are less scientific and more political. That is the first problem in India's vaccine policy. India wanted to show to the world that it is the pharmacy of the world. We are a Vishwa Guru. We are the vaccine capital of the world, and we can not only serve ourselves with the domestically produced vaccines, but also we can serve the world with these domestically produced made in India vaccines. So you basically decided that Covishield and Covaxin should be adequate for India's purposes. Serum Institute and Bharat Biotech should be adequate to produce for India, despite evidence in front of you that they do not produce more than half of your requirements if you want to complete a process in 1 year. Right? So Covishield and Covaxin were given permission in January. But when Sputnik V came for permission in February, you denied permission to Sputnik, saying they did not have local bridging trial. Sorry, they did not have immunogenicity data. I'm sorry, they did not have immunogenicity data. But when you gave permission to Covishield in January, did Covishield have immunogenicity data? No, it did not have. Yet you gave Covishield permission because it was a made in India vaccine. But the same criterion you did not apply in the very next month to Sputnik V vaccine. That's why you call it a political decision, not a scientific decision. The second example is of Pfizer. Pfizer came to India and Pfizer wanted permission, saying, but it was returned, saying that Pfizer did not have local bridging trials. Okay, but when you gave permission to Covaxin in January, it did not even have phase 3 data with it. Forget any bridging kind of trials, but it had not completed beyond phase 2. In fact, we are talking about it in June now. Even now, Bharat Biotech has not completed phase 3, and the data is not published yet officially. But we have been giving Covaxin to everybody in India. Right? So basically, if you look at these experience, there has been zero uniformity in the criteria that you apply to give vaccines permission. You apply one criterion to Covishield and Covaxin. You apply another criterion to Sputnik V and Pfizer kind of companies. But you later realize the problem. You realize the blunder of this problem, of this kind of a decision, when by April 2nd week, you were faced with a very serious shortage of vaccines. Right? At that point of time, you scrambled for vaccines everywhere. On April 13th, you made the decision that everybody who has the permission of US FDA and so on can actually come to India, and we will give them automatic emergency use approval in the country. Right? In fact, VK Paul, the Niti Aayog member, was saying, we hope and we invite the vaccine makers like Pfizer, Moderna, Johnson & Johnson and others to be ready to come to India as early as possible. as early as possible. They had come in February. You denied them permission. Why? Right. So this is the first problem that you'll have to know, that the diversification of vaccine availability in India, or vaccine permissions and or approvals in India was not there. You basically chose to go with political gains rather than listen to scientific advice in this matter. That's the first point. Second point is, did you make at-risk investments in vaccine research and capacity expansion? Again, the answer is no. Look at countries across the world. Oxford AstraZeneca vaccine. About 97% of the funding that went into Oxford AstraZeneca vaccine development was public funding. Okay, look at a company like Pfizer, its associate BioNTech. BioNTech received a grant, not a loan, a grant of about 375 million euros from the German government. It also received debt financing worth 100 million euros from the European Union. That's how BioNTech developed its vaccine. Right? Look at Moderna. Moderna received $2.5 billion US dollars to develop the vaccine in collaboration with the US government. Right now, many countries did invest, and those investments failed also. That's why it's called at-risk investment. Right? European Union funded this company called Sanofi for its vaccine, but it failed. But it was worth it. You tried and you lost. It's fine. Right? But India made zero at-risk investment in any vaccine company, public or private, right, throughout the last 1 year. Did not make any at-risk investment. That was the only money that Serum Institute received during this time is a $300 million funding from Gavi, not the Indian government. And that's precisely what gives the audacity to Adar Poonawalla to stand up and say, I need super profits because you've not funded me. Right? So that's a second big mistake. The third big mistake is failure to book advance purchase orders for these vaccines. Okay? Countries had ordered vaccines from June 2020 itself. June 2020 itself. Right? Bangladesh had ordered its vaccines in November 2020 itself with Serum Institute. India ordered its first lot of vaccines with the Serum Institute only in January of 2021. And that too a trickle. Right? And by the time the vaccine capacities had been committed across these vaccine companies, it was committed to supply to different agencies, different countries, some to Gavi and so on. Right? So you could not make the vaccine companies, particularly Serum Institute, commit to a large supply to India. So basically, if you see the three major mistakes are mistakes you made in emergency use approval, and you relying on politics rather than science in deciding what vaccines you need and what you do not. Second is failure to make at-risk investments in vaccine manufacturing and research. Third is your failure to book vaccines in advance from the vaccine companies. These three are the context. These three give you the background for why by April you had such a bad vaccine shortage in India. In fact, after April 7, it has improved in the last 2 weeks or so. But beginning from April 7, throughout April and throughout May, vaccines were in serious shortage. There were simply not enough vaccines to give to anybody. It was in this context that the government moved into what is now clear to be a Tuglakian move, but very clearly a rather stupid policy turn on the April 19th with effect from 1st April, whereby it liberalized vaccine sales. What it did was it created quotas, 50% for central government, 50% for state government, and 50% for central government, 25% for state governments, and 25% for private hospitals. So it liberalized vaccine sales like this. It also deregulated vaccine prices. Basically, vaccine companies can transparently self-set prices. That was the announcement. Okay, with effect from May 1. What happened? Vaccine prices went up from 150 rupees to 600 rupees, 1,200 rupees, and so on. Right? That's what Covishield and Covaxin prices ultimately became. right? Without taxes and also without service charges of hospitals and so on. So this kind of tripling or quadrupling of prices over just a week was a very important feature of the last week of May in India. What it did was this 150 rupees per dose was actually providing these vaccine companies with a fair normal profit of 100%. 100% is not normal profit, but still let's call it normal profit. 150 rupees per dose was actually providing these companies a normal profit because the manufacturing price is not more than 30 to 80 rupees per dose, according to observers inside. So this was unacceptable, however, to the vaccine companies. And that's the economic side of the April 19th decision. The vaccine companies said, in fact, Adar Poonawalla openly said that we are not content with normal profit. We are actually looking for super profit. And he even said the super profit level he wanted, the price at which he wanted the super profit. He said 1,000 rupees per dose. That's what he wanted. Right? So basically, you have a situation where vaccine companies are pushing the government to raise prices substantially so that they could make profits. Okay. Krishna Ella, who once upon a time said my vaccine would cost less than a bottle of water, now says he wants the maximum price for this vaccine. Last week, his company has said that 150 rupees per dose is not profitable for them. The same person who said my vaccine would cost less than a bottle of water. Right? So this kind of pressure was building upon the government, and the government succumbed. And the April 19th policy allowed the central government, allowed the vaccine companies to raise vaccine prices as they please. And vaccine prices, as I said, tripled or quadrupled in a short period of time. Now, this was the economics of that policy on April 19th, but there was a politics also to it, which is that given that the vaccine shortage was continuing and was sure to continue for quite a bit of time, the central government very clearly wanted to shift the blame from itself onto the state governments. It is very clear if the vaccine shortage continued, the blame would come on Prime Minister Narendra Modi and the central government. They wanted to deflect attention from them, and so they gave all these responsibilities of 50% to state governments and private hospitals. And later, if there is a vaccine shortage, if it continues, then you can actually blame the state governments for not ordering vaccines adequately, not making adequate efforts to procure vaccines directly from vaccine companies, and so on. So this was the politics of that April 19th policy. So you have an economic side where you allowed vaccine companies to raise prices substantially, and you had the politics of it where you wanted to shift the blame to the state governments. It was in this context that we had the policy being implemented in the month of May, where it was an absolute disaster. Okay, May showed very clearly what a blunder, how manyth blunder we don't know, but that this policy was clearly a major blunder. Right? Supreme Court even took up the case. Suo motu heard the case very, very seriously. It raised very important questions on this policy. The state governments were simply not getting vaccines. They tried for global tenders. They were returned, saying that these companies like Pfizer and Moderna will deal only with central government, not with state governments. They tried to talk to vaccine companies. Phone calls were made to Adar Poonawalla. Adar Poonawalla escaped to London, and he said, chief ministers are calling me and threatening me. So it became a complete mess. Right? Private hospitals. There again, the inequality was very clear. An Indian Express report actually showed that of all the vaccines that were given to private hospitals, 50% of the vaccines were cornered by 9 corporate-led private hospitals, Medanta, Fortis, Apollo, those kinds of hospitals. Right? So not even smaller private hospitals got enough. In fact, the remaining 50% was received by just 300 private hospitals, not more than that. So you can see the pie size is very small, and the big hospitals took away 50% of that pie. Okay, so so it became the case that even if you are ready to pay 1,300 rupees for a dose of vaccine, you still can't get the vaccine. That was the situation in May. So basically, the vaccination rate in India As a result, which was above 40 lakh per day in the first week of April, fell to just about 15 lakh per day over many days in April, the remaining part of April. And by May, it had fallen to about 10 to 12 lakhs per day on many occasions as well. As a result, if you take the whole of May, you will see that the vaccination rate fell from 29 lakh doses per day in April to about 18 to 19 lakh per day in May. About 10 lakh doses per day was the daily vaccination rates in India. This became very clear. The Supreme Court intervened. Supreme Court said that this policy is prima facie arbitrary and irrational, and it had to be withdrawn. But even in withdrawal, the whole process, if you see, this withdrawal was not complete, right? This withdrawal very clearly was partial. Okay, what happened very clearly was that 25% for private hospitals was retained, and only the 25% of state governments were taken up by the center. The problem in this policy is very clear. The problem of doing this is very clear. By allowing 25% to be kept by private hospitals at exorbitant prices, 750 rupees per dose for Covishield and 1,380 rupees per dose for Covaxin. Very clearly what you're doing is you are reserving 25% of the vaccines for the rich. It is essentially a reservation for the rich. That's the kind of perversity in the design of that policy that you saw throughout. You saw that, of course, throughout May, but even in the revised policy applicable from June 21st, this abnormality, this anomaly very clearly remains. So the ideal state is very clear. Sundar would agree with me. He has written about this extensively, that 100% of vaccines should be procured by the center, as has been the case in past universal immunization programs, given to the states free of cost, which will in turn give it free of cost to people. Now, this is the most ideal situation possible, right? But this was not followed in India. For clear political economy reasons, you wanted the vaccine companies to, you wanted to give them space to make their private profits. Very clearly, the retention of 25%, even in the revised policy, is very clearly done to allow private hospitals to keep their share, so that vaccine companies can at least make up for some of their losses through the super profits made over the volume of this 25%. Okay, and this is the extent of perversity in the policy that you see. So inequalities in vaccine provision are clearly likely to continue even after the revision of the policy that we are talking about here. Now, there is an additional element in this policy that I want to talk about, which is related to intellectual property rights. Now, Covaxin very clearly is not a private sector vaccine. Covaxin, it has received serious amount of criticism on multiple fronts, but I'm going to stick only to the ownership question here. It is a product of public funded research in India. Okay, the Covaxin, the vaccine is based on the SARS-CoV-2 strain, which was isolated by the National Institute of Virology in Pune and passed over to Bharat Biotech. NIV functions under the Indian Council for Medical Research. ICMR so transferred the strain to Bharat Biotech for development and manufacture of this vaccine. Now, from the affidavit given to the Supreme Court, we know that of the 12 steps which are to be followed in the production, which were followed in the research, development, and manufacture of Covaxin, out of the 12 steps, 7 steps were funded and controlled by the ICMR, and 5 steps were controlled by the Bharat Biotech company. Now, so very clearly, the IP throughout April, there was no clarity at all as to who owned the IPR. A lot of us wrote about it. It became a controversy quite a bit during the end of May and April, and finally, it was in the affidavit given to the Supreme Court that the central government admitted that it was the IPR over Covaxin was shared between central government and that central government means ICMR and Bharat Biotech. Now that raises more questions immediately. Here is a case where the government has a stake in an IPR. If the government has taken an IPR, that very clearly means the taxpayer has funded the development of the vaccine. What did it do to leverage that IPR to provide vaccines in good quantity, to mass produce the vaccine and make it available to people at low prices? The answer is nothing. Despite government having shared IPR over the vaccine, Covaxin, it allowed Bharat Biotech to have an exclusive license to manufacture the vaccine for many months. It even allowed Bharat Biotech to enter into agreement with shady US companies like Ocugen to supply vaccines to the US and make money from it, with only 5% going to ICMR, of course, as royalty. Now, this was allowed. So Bharat Biotech was allowed considerable space to profiteer in this whole process for a considerable period of time, from January to April or May. It continues to be the case because after this controversy arose, after chief ministers wrote letters, after the Supreme Court raised the issue, what the government has done, it has allowed 3 public sector units also to participate in Covaxin production. But repurposing of laboratories is a very tedious process, and that process will be completed only by the end of the year. For example, Hafkind Institute in Mumbai, or the company in Bulandshahr, or the company in Gujarat. All these companies are trying to repurpose, but the question is, when will they complete the repurpose and start production? Not before 2021 December is what we get to understand. So very clearly what you see is Bharat Biotech is effectively going to have the exclusive license to produce the vaccine for the whole of 2021, because others will start producing only by the end of 21 or beginning of 22. Now, this is the huge big anomaly in the Indian case, particularly because India and South Africa have moved a resolution in the WTO saying that IPRs over vaccines should be temporarily waived throughout the period of the pandemic. So you basically go to WTO and ask for a waiver of the IPR over vaccines. But in India, the same government is sitting on an IPR, but not allowing it to be mass produced on the basis of non-exclusive licenses. There's an extraordinary contradiction in this kind of a policy position on the part of the government of India, which is a matter of very serious concern. Okay, so there are two concerns that remain, in my view. One is the 25% reservation for private hospitals, which is essentially a reservation for the rich. And the second is that the IPRs, which are resting with the government of India, at least partially, is completely unleveraged at this moment of time to mass produce Covaxin. Covaxin has other problems. Bharat Biotech has much to answer with respect to why the phase 3 results of its clinical trials are not yet out. In fact, there is a lot of adverse commentary that it has received from different quarters, thanks to observational studies done by other independent researchers based on how much antibodies they produce and so on. That's a different question. Sundar is a better person to comment on all that. I shall comment on only the political economy of this whole exercise. In fact, it's not just ICMR. In fact, CSIR, that is the Indian Institute of Chemical Technology in Hyderabad, has also contributed to the development of Covaxin. In fact, they produce what is called as the agonist molecule, which is used in the production of an adjuvant in the vaccine production sequence. That was another important contribution made by public sector scientists in India. I'm going to close my presentation with a quick statement on why I think the 25% quota given for private hospitals should also be taken up by the central government. Central government should be the single procurer of vaccines in the country, and it should be provided to people freely and universally. I think there are 4 or 5 reasons, but I would like to state. I'm not going to go into detail with them, but I'll quickly state them. That's all. First is, vaccines are global public goods. They should be available to everyone, everywhere, be affordable, safe, effective, and easily administered. Very simple. The only way it can be done is to give vaccines free to everybody. That's what most capitalist countries of the West are doing. United States, United Kingdom, Germany, France. Everybody is giving vaccines free of cost except India. Okay, so that's a serious problem. India is not giving vaccines free, even though it is considered a global public good. The second important case for it is that it is a constitutional obligation of the Indian state. Article 21 lists right to life as a fundamental right, and through many judgments of the Supreme Court, right to free vaccine can be read as a subset flowing from right to life under Article 21. Thus, it is the constitutional obligation, the responsibility of an enlightened welfare state to provide vaccines free of cost to everybody. That's the second reason. Third reason is vaccine hesitancy. Vaccine hesitancy usually results due to confidence, complacency, and so on. But in this case, in India, affordability becomes an additional reason why vaccine hesitancy becomes even more acute or amplified. And that's a third reason why. So you should simply eliminate the problem of affordability from the question of vaccine hesitancy. And that's yet another reason why vaccines should be free. Fourth is vaccines were publicly funded. Oxford vaccine, Covishield was publicly funded. Covaxin was publicly funded, right? Why should the taxpayer pay twice for a vaccine, which is a public good in nature? Basically, he's already paid through his taxes. Why should the taxpayer pay twice? So this is a fourth reason why vaccines should be free. Fifth is, if you take the vaccine prices from private hospitals, they basically take up almost the whole of the monthly income of most poor households in India. They are simply excluded from that. So there's a very clear question of discrimination, constitutional discrimination against the poor by keeping the 25% quota for private hospitals alive. And that's why that also should be taken up by the central government. So basically, there are a number of cases like this, number of reasons like this, where as to why vaccination should be free and universal for everybody in the country. Right? But as you see, the central government has not been doing that, and that's something that needs to be politically questioned by all progressive-minded people in the country. I shall close my comments here, and I hope I kept to my time, and I'll be happy to take up more questions along with Sundar in the remaining time. Over to the moderator. Thank you very much for this opportunity.
Thank you so much, sir. It was a very detailed explanation of the vaccine policy. Thank you so much. So to summarize the discussion so far, I think Professor Sundararaman explained about the broad need for a strong public health infrastructure and public health system to control the pandemic, especially emphasis on not blaming the victims and building a extensive surveillance system to control the pandemic. And then Professor Ramkumar mentioned about the three fronts in which the government of India failed in its vaccination policy, as a political decisions, as a failure to procure vaccines, and also failure to invest in vaccine production. So thank you so much for this discussion so far. I hope we can open the floor for questions. So right now we have one question on chat. So this is to Professor Sundararaman. The question is on the failure, on lockdowns being admission of failure. So the question is the question by Azhar is requesting to explain more about the impact of these policies of lockdowns. So haven't these policies led to disruptions in healthcare, especially for the working class and marginalized sections? Also, this has increased food insecurity and exacerbated poverty. What has been the impact of this on public health? So this is the question, sir.
Yeah, so there is little doubt that it has had these adverse effects. Okay, there's no doubt that it has led to huge disruptions in livelihoods. And the more precarious the employment, the less the social security coverage, the more it has done so. The rations and the free rations supplied often did not reach many people who did not have some form of identification or recognition or residence to be able to access it. and some of them were the most vulnerable amongst them. So there is exacerbation of all the problems that existed below also. But having said that, the question is not that. The question is, were the lockdowns when they were imposed inevitable? So the general statement that is taken is that, look, we know there is a lot of pain that the lockdown causes, but what to do? We have no choice. If we don't do it, the choice is between loss of lives and loss of livelihoods. So the one simple, we need to know two things in this context. First is that the loss of livelihoods and the socio-economic pain that is caused is highly inequitous. So it is much more on the poor and the marginalized. So that the burden of the lockdown is borne by the poor. So that is the first thing we need to understand. But the second is, why is it inevitable? Because at one point you are reaching a certain amount of caseload, which is collapsing the whole hospitals. Right? If your cases have become so high that you have run out of oxygen, you have run out of beds, and cases still continue to rise. And all your hospital staff are tired, they are exhausted, they are not able to continue in their thing. A collapse becomes inevitable. And there is a need to urgently flatten the curve, which means that the number of new cases being generated has to be flattened. So you don't know exactly where the cases are coming from, so you stop all activity. Now, it may be that the migrant labor that is going to work in construction worker can be relatively protected and they can lead to less spread, but you don't know that. You have to apply a broad brush across all activities. You are not you're not based on evidence that the spread is most in this sort of interaction. Second, you have actually allowed it to reach to that part. If you could have stopped the second wave at a lower level, which would require much better contact tracing, much better use of isolation, when patients go from hospital to hospital searching for a bed, they are infected patients using public transport, you are going to spread disease. So the disease is not spread only because of things that can be locked down. The disease is also spread because of people desperate to seek care and admission. So if you do not have isolation facilities, if you do not have proper quarantine, if you do not have adequate testing, then at one point the cases reach a point where the lockdown becomes inevitable. But if you had all of this, maybe you'll have a lockdown, but it will be less and it will be a very limited time and it will be of less activities that you need to limit. Now it's a complete crash and the system crashes to a halt. And if you have good public health measures, the curve should not reach the point where it requires flattening. You should be able to flatten the curve with other public health measures, not resorting to a law.
Thank you, sir. I think we have a hand raised by Amil. So I request Amil to unmute and ask the question, please. Amil? Okay, fine.
Hello.
Okay, Amil, please carry on.
Yeah, actually, I have like three questions. First one is to Professor Sundararaman. So there has been a debate going on in my state whether post-COVID deaths should also be considered when we look into the COVID death tally. Because and one thing the state government is saying is that as per the WHO guidelines, a person who has tested negative and has died should not be considered, should not be clubbed under the fatalities under COVID-19. That is my first question. And the second and third questions are to Professor Ramakumar. So as you are a former member of the Kerala State Planning Board, my question is, had there been a planning commission in India, don't you think that the vaccination policy would have been on a better scale, or would have been implemented properly? And my third question, I think you have partially answered in your talk. So, like, it is regarding the public involving public sector units and COVID in the COVID vaccine manufacturing. So, like, my question is, had the government taken this step, especially during the initial days of the lockdown, to revive the existing public sector units? For example, we have the Hindustan Latex Limited, HLL. Had the government taken these initiatives, say when the country faced the first wave of COVID-19, so probably had these steps been taken, probably would have been like vaccine. So we would have achieved self-sufficiency in vaccine, isn't it right, sir? These are the three questions, sir.
First, let Professor Sundararaman take the first question, sir. Then we'll move on to the next two questions.
Yeah. So the ICMR had released, based on WHO guidelines, the criteria for death reporting, which was reasonably really robust, which said that you have deaths reported, and if there are deaths that occur with COVID-19 positive, even if there are comorbidities, it is attributed to COVID-19 deaths. And if there are COVID-19 negative, you can put them as suspect deaths, especially if the tests are weighted or are still coming. But if the clinical feature is very clearly of COVID-19 and you suspect COVID-19. Now, if it is negative, there is a case for other causes of deaths. But very often, because of the high degree of false negativity, doctors do go by clinical symptoms. And if you have a typical viral pneumonia and ARDS with a fever dying at this period of time, there is no great requirement to prove anything else. It is a COVID-19 death. And international WHO standards does allow that. Okay. Second, you must remember that as the disease, if you are on ventilator for a long time, you may actually, the COVID-19 test may turn negative because it's no longer infective, it's no longer colonizing the throat. The damage is now being done by the runaway immune reaction of the body, not the virus. So after the second week, the virus load decreases, but the immunokinetic action, the cytokine storm is what is doing the damage. So you will die directly out of COVID-19, but for the same reasons why you died out of it, you may be testing negative. So it makes no sense to exclude them also. So actually, and I don't think the ICMR guideline excludes that as it stands, but it allows for the suspect, and world over, we don't even report suspect deaths. So we would know we are on the right track if they reported the deaths and we suspect it. Here, by a different set of cases, you have put the disease is attributed to some other thing and not to this. And at some point, it really doesn't matter. Further, there has been a move towards now recording excess deaths as different from recording only COVID-19 deaths. Because the excess deaths may be due to lack of other care, emergency, cardiac care, it may be due to TB, it may be due to diarrheal care that could not receive things. So it doesn't really matter. It is a death that happened due to the pandemic, okay, though not necessarily due to the SARS-CoV-2 virus. So in some sense, therefore, more and more studies move towards excess deaths. Then you are able to see where you have information in those patches where you have past and present information. You are able to see that the death toll can be 4 to some 15 times higher.
Yeah, before I start answering the questions posed to me, I request Dr. Sundararaman to kindly see the last question in the chat box, which I think is more appropriately answered by him rather than me, which is related to Pfizer and its indemnity questions. I'll be happy to answer other questions. A word about Kerala, which Dr. Sundararaman answered very effectively. The case in Kerala that you're raising is very different. There, the question is that the nature of deaths are not decided whether this is a COVID death or not, was earlier decided by a state level doctor's body. And that state level doctor's body did not have adequate information to classify a death as COVID or not. But now the methodology has changed, in my understanding, and a local level body, a district level or local level body of doctors will, with more information about the case, will actually decide on whether it is a COVID-19 death or not. As a result, you'll quickly see that COVID-19 deaths have been rising. In fact, many of these deaths have happened in the past, but they are not being reported. So that's a good thing. It's a good positive change has happened, which is there is more transparent reporting of deaths in Kerala. Even though, regardless of all these things, Kerala's mortality rate or case fatality rate remains one of the lowest, despite adding up the new cases of deaths also. So that's about it. Second, your question was about planning commission. Look, planning commission was effectively dismantled with liberalization. Okay, so whether there is a planning commission there or not, whether there is a planning commission on paper or not, was not what decided its importance or significance. What decided was that there was the significance that economic policy gave to an institution like Planning Commission to develop policies and to follow those policies. Planning Commission was effectively weakened or increasingly weakened from the 90s itself. And even when it survived in the second UPA regime, its importance had effectively been whittled down to an advisory body. Most decisions were taken politically by the government itself. So that is one part. So the point is not whether there is planning commission or not. In fact, planning commission should be there, no doubt about it. But even when it is there, the question is, what kind of importance do you accord to it in your whole policy framework? That was very poor or very weak under liberalization. What states like Kerala have tried to do is to retain the whole exercise of planning, at least to a large part of the funding that happens from the part of the state government. And that makes a difference, of course. The second important question that you raised is about public sector. Here again, as part of liberalization, what you saw was a consistent defunding of public sector vaccine enterprises. What you saw from 2008, 2009 onwards, people like Sundar have been on the forefront of those advocacy movements, where you saw vaccine companies, 3 or 4 of the major vaccine companies in the public sector being closed down, most others confined to a status of irrelevance or insignificance because of a complete absence of funding to construct new laboratories, to appoint new research staff, to conduct research and development, and so on. Basically, you left the area free for large companies like Serum Institute of India. That's what you saw throughout the period of liberalization, and it was the same under UPA as it was under NDA. So, and you suddenly realize the problem when the vaccine shortage hits you, and you realize that you have weakened your public sector institutions to such an extent that even with immediate large-scale funding, it will take about 12 months to repurpose their laboratories and restart production. So that's a serious problem. So it's an impact of weakening that has progressed over at least 2 decades now. Right. That is so. This provides a big lesson for countries like India. It's not enough to pat on your back saying you're pharmacy of the world. You have to develop a good public sector infrastructure also, along with private sector will of course continue to flourish because there's enormous amount of export opportunities there. But the weakening of public sector vaccine companies was a mistake, and it has been. I hope it has been realized as the pandemic has proceeded. That's what I will provide as quick answers to those 2 questions. But I think this particular question should be directed to Sundar. Thank you.
Yeah. So I think this indemnity thing is really a scam. That why should the government actually pay for should indemnify Pfizer or for that? And that's why Serum Institute is now also asking for indemnify. If you are doing for Pfizer, then you will do it for all vaccines. Why will you do it only for Pfizer? Pfizer is just using its monopoly power over vaccine supply in a tight situation because it has enough market. It doesn't need to supply you. You're not anyway a major market. So it's trying to set new precedents for itself and just using bargaining. Eventually, they may get you to indemnify their vaccine and not supply you vaccine also. I think they are much more playing a game of it. I don't think they are really very seriously engaged, but they are imposing huge conditions even on other African countries, where even their assets have to be pledged for different reasons to the Pfizer. So they are using their monopoly powers to bargain extraordinarily evil conditions on some of these issues. So it's not something very easy. Another side point is most of the vaccine prices builds in indemnity clauses into the pricing mechanism. So when they price, they actually calculate in case there is that risk, that is also calculated. So therefore, if government indemnifies, they should compensate by lowering prices, which also is not something that they are doing. So that is another business problem in this. Then you have raised the issue of the whole discussions around COVID, Covaxin trials, and the issue of vaccine hesitancy. I don't think community level vaccine hesitancy relates to that. Community level vaccine hesitancy relates a lot to what we call the old awareness factors. That, you do get people who become positive, who will get the disease afterwards. How do you understand it? People get fever. How do you understand it? People don't get fever. How do you understand it? So there's a lot of question and answers, basic information, which people need to know that a vaccine, why should I take a vaccine when I don't have the disease and when I have not had the disease? Why should I take a vaccine if I have recovered from the disease? These are not simple answers. They take some answering. So therefore, sharing information, being able to convince people, persuade, health communication as a major role. So I don't think it relates to this. But what Covaxin's, all the embarrassment around the way the trials were done is that it has made it very difficult to certify to an international audience. So you haven't got the WHO certificate yet. It's not even in the line. And if you don't have a WHO certificate, then when your international travel is going to come, Covaxin is not going to be held valid. You would be in a real suit. Similarly, a whole lot of other compensation issues, a whole lot of this international certification is needed for other things also. So at some point, you are going to have for export, for example, you are going to require international certification. So you are going to actually get into problems with this. So even you see China and Russia have gone ahead with their international certification. Now, we have not yet published phase 3. What the phase 3 shows is not very clear. We run a risk that the phase 3 data could have problems in it. And therefore, it's not a good thing that they have done. Finally, we have the worry about its ability to manage the mutant strains. That requires a system where you're constantly rechecking the vaccine. Every time there is a virus of concern or announced, anywhere in the world, you must get adequate samples of that and test your vaccine against that. It is necessary, not only vaccine, but even your diagnostic. The sensitivity and specificity will change. And you have to actually keep testing it against that. That whole process requires also that you have your entire data that is transparent, and then you are able to see whether it improves, whether it doses. Your processes are visible and they are ongoing. You have baseline reports and continuous reports coming. Now this scene has got so messed up that when somebody claims that Covaxin is effective, we are still debating. Now you have to debate whether it is effective against a new variant. And your last one itself is not proven. So it's a very unhappy situation to be in without linking it to the problem of vaccine hesitancy in the community.
So if I may, I'll ask one last question, sir. So I wanted to understand about the differences in caseload across regions in India, especially given that regions with strong public health infrastructure like Tamil Nadu and Kerala reporting much higher cases, both in terms of numbers as well as per million or per thousand. But you other states, like, is it a problem with only reporting, or is it like even the other states claim to do much more testing, like the number of tests and such are claim to be much higher, but still states like Tamil Nadu and Kerala, which have much higher, much better infrastructure, are reporting much higher numbers. So I want to understand how it.
So broadly, you have the relationship will be with a combination of three things. One is tests per million. Second is the proportion of tests which are RT-PCR, and as different from rapid active tests. And one must also worry about the indications for testing, whether they are on febrile patients or whether your indications are too low, and the test positivity rate. Okay. So if you are testing the whole village because one person has turned positive, then you will have a low test positivity rate. You will have a lot of test negatives. It's very confusing. But if you are following a comparable protocol, your test rates, if you go by just testing rates per million, most of this thing can be answered. So the test rates per million in Kerala are much higher than India. That itself will answer that. But where it does not match, you will have to add in the other things of test positivity rates and also the nature of testing protocols that are being followed and the type of tests which are being used. Having said that, we still don't really know. And last time we said this about Chhattisgarh, but now Chhattisgarh has had a pandemic. Maybe the epidemic has still not arrived fully, and that's where the third wave is going to strike. In Tamil Nadu, for example, if you remember last time, in fact, I came on TV repeatedly saying I'm worried about Coimbatore because the Coimbatore is reporting very few cases, whereas all the other centers are reporting very high cases. In retrospect, I exonerate Coimbatore because now they have made up for it. Now they have been peaking all the time. So last time, perhaps genuinely they had less cases because they had less infection. Fair enough. So the infection caught them in the second wave because there was a greater non-immune population available. So there are areas in the country where the pandemic has not arrived. In Chhattisgarh, I was told of a number of primitive tribal areas that it has not arrived. But there you see, it may not come, but the day it comes, the whole tribe may get wiped out. So these small number tribes have historically got wiped out by infection wave that comes in. And thankfully, for the credit of Chhattisgarh, they are taking some of these groups as priority and giving them vaccine. Because you have no case, and then all dead. It's a very, very risky thing because primitive tribals may not have any contact with society and civilization. So they are reasonably protected. So the moment it spreads into them, then it can wipe out populations. And that's been the history of ecological history has always shown that. So therefore, you have to view these things through all those lenses on that.
Thank you, sir.